Welcome back, ladies and gentlemen, to the Your Go-To Doc YouTube channel. I'm Dr. Robert Feldman, board-certified neurosurgeon, and today we're going to be talking about spinal cord stimulators. These are devices that are implanted into the human body on the spinal cord to basically treat chronic pain. We're going to talk about why the spinal cord stimulators work, how they work, what they look like, who are the good candidates that would benefit from a spinal cord stimulator, what's involved in the surgery, what to expect before, during, and after the surgery, the risks of the surgery, as well as some common questions that are associated with getting a spinal cord stimulator. So let's get to it. Your Go-To Doc YouTube video about spinal cord stimulators. So let's talk about what spinal cord stimulators are used to treat. Big picture, they treat chronic pain, which is defined as pain lasting more than 3 to 6 months. I can tell you from experience, though, that most of my patients will have had chronic pain for years, and this can come from something called failed back surgery syndrome, where you've had one or more back surgeries or spine surgeries for pain, and the pain has persisted or worsened or has not gotten better enough. It can also be for peripheral neuropathy pain, pain from something called regional pain syndrome, and this is both in the legs and arms, as well as back and neck. But spinal cord stimulators are best for limb pain, arms and legs, more than they are for axial spine pain, meaning neck and back pain. So if you just have neck pain, just have back pain, spinal cord stimulators are probably not going to be worth it. But if you do also have a lot of leg or arm symptoms, you could definitely consider this option. And something to keep in mind is that patients with chronic pain don't just have pain. The syndrome of chronic pain can affect all aspects of their life, severely affecting their quality of life. This includes things like sleep, mood, relationship with others, ability to work, ability to accomplish activities of daily living. So if a spinal cord stimulator can, let's say, decrease your chronic pain by 50% or more, and therefore improve all these other aspects of your life, it could certainly be worth it. So before we talk about the actual device and how it's put in, let's talk a little bit more about what is chronic pain and how it works, and why these stimulators therefore can be effective. So how do we actually perceive pain? We stub our toe, we cut our knee or our hand, we think, oh, it hurts, I've got an injury to my hand, my knee, or my toe, and it hurts in my toe. But the actual process of perceiving that pain is actually not occurring in the toe or the knee or the hand, it's actually occurring in the brain. So there is a part of the brain called the somatosensory cortex that has a representation of the body on it. A specific spot on that part of the brain is for the face, the head, the neck, the arms, the legs, etc. And pain fibers from the area of the body that's injured, the toe, the knee, the hand, travel through the arm or the leg into the spinal cord, up into the brain, to an area called the thalamus, which is kind of in the center of the brain. And from there, nerve fibers go off to all parts of the brain. Parts of the brain that control the emotional aspect of pain, parts of the brain that control the physical feeling of pain, and I'll show you some diagrams of what that looks like. But coincidentally, and maybe luckily, the fibers that travel from, for example, the leg into the spinal cord and then up into the brain, those pain fibers travel through what's called the spinothalamic tract, spine to thalamus tract, spinothalamic tract. And coincidentally, those fibers run along the spinal cord in the back part of the spinal cord. This is important because during the surgery, the access point to put the spinal cord stimulator paddle or lead is along and against the back of the spinal cord. So it's quite lucky that that's where all those pain fibers go. It means you don't have to put this device on the front of the spinal cord, which would be much harder to get to. So getting back to that idea that the pain fibers run from, let's say, your stub toe through your spinal cord up into your brain, it provides a spot that you could possibly get to to interfere with the communication of that message up to the brain. And that's basically how spinal cord stimulators work. You're basically applying a small electrical current through the device onto the back of the spinal cord. And that current theoretically stimulates what are called inhibitory neurons, which are nerves that suppress communication between nerves. So the spinal cord stimulator paddle lead or electrode sends a small electrical pulse which creates these impulses in inhibitory neurons, which then block the signal that goes from the pain nerve up into your brain. And we're going to take a look at some pictures of what that looks like. That stimulus to your spinal cord can be adjusted, especially with modern technology nowadays. You can adjust all sorts of parameters of that signal. The amplitude or strength of the signal, the frequency of the signal. You can use various modalities like burst signaling. All of these variations in the way that electrical impulse is delivered to the nerves in your spinal cord can kind of tweak or tailor the effect that you can get from that stimulation. Not only that, it can get rid of what was common in the old days, which was side effects from this stimulation, namely a numbing, tingling, or buzzing sensation which was caused by unwanted stimulation of nerves in your spinal cord. Now, with certain variations that you can program into the stimulation, you can prevent those side effects. So the modern day spinal cord stimulators are very effective and can be very tailored to the individual for not only which spot on the spinal cord you want to stimulate, but how you want to stimulate it. So let's take a look at some pictures to kind of describe that in more detail. So here we have a representation of the pain pathway from the leg to the brain. So on the left side of this picture, you can see, let's say you scrape your knee, the nerves in your knee send a message up to the back of your spinal cord. Dorsal means backside. So the spinothalamic tract that I mentioned earlier runs along the backside of the spine. So these nerve fibers will go up the spinal cord into the thalamus, and from the thalamus to what's called the somatosensory cortex. The cortex is on the surface of the brain, and the sensory part of the cortex for touch and pain and sensation runs along the outside of the brain here. If we look on the right side of the picture, you can see a picture of the brain on the right here, the green and the blue. The green stripe is the somatosensory cortex, and on the brain, there is a representation of the human body, and that representation can be seen on the surface of the brain here. And you can see it's not a spatially correct representation. The nerves in the hand make up a large portion of the space on the surface of the brain, compared to, let's say, the elbow or the knee or the lower leg. That's why the hand is so sensitive to sensation, is because it has a lot of nerve representation on the brain. Same thing with the face. So here's the throat, the tongue, the face, the hand, the elbow, the shoulder, the chest, the thigh, the knee, and the lower leg. So if you scrape your knee, you're eventually going to send fibers up through the spinal cord to this area of the somatosensory cortex. So we'll take a look in the next slide, a closer picture of this area here where the nerves come into the spinal cord, and there's an opportunity for a spinal cord stimulator to stimulate inhibitory neurons to suppress the signal here. So let's take a look at those pictures. So this is a close-up representation of the pain fibers in the spinal cord. On the right, you can see the red line represents the pain fiber coming into the spinal cord and attaching to a secondary nerve, which then heads up to the brain and the thalamus, and then eventually the sensory cortex. But here you can see the green line represents the spinal cord stimulator. So in the box on the upper left of this picture, you can see the spinal cord stimulator represents the green impulse. That green impulse activates this inhibitory neuron, which is a negative effect neuron. So by stimulating the neuron here, it increases the negative effect here, and this negative effect blocks the pain fiber coming from your leg going up your spinal cord to your brain. So the mechanism of action of the spinal cord stimulator occurs here. It decreases the ability for these pain fibers to communicate with each other in the spinal cord, which ultimately leads to a lower signal in the brain for pain. So this is a generalized representation of how the spinal cord stimulator suppresses the signals that are going up to the brain. In addition to the gate theory of mechanism of how spinal cord stimulators work, where they promote inhibitory neurons to activate, here is another possibility where there is direct conduction block of the signal occurring along the spinal cord. So this black and white segmented thing is the electrode for the spinal cord stimulator. This blue cone-shaped thing here is an area that there is a hyperpolarization or change in conduction capability that's created by the impulse going along the electrode here. And here the nerves traveling along the spine are interrupted here and are unable to signal or electrically communicate down the nerve. So this essentially blockades the impulse from traveling along the nerve here. This is more of a direct effect of the electrical impulse from the stimulator affecting the conduction of the nerves, as opposed to the other slide I just showed, or the other picture I just showed, which is the enhancement of inhibitory neurons that are preventing the signals from traveling. So before we start talking about how I put these implants in during surgery, let's look at the parts of this device. Up at the top of this image, you will see the paddle leads. They come in different sizes and shapes. I think this is the lead I would use the most often, but you can see each little silver box there is an electrode that can be separately controlled from the controller. But you can see overall there are many different styles, shapes, sizes, number of leads, etc. But for example, you could set this particular electrode to a certain amplitude and frequency, and this guy down here to a different one. If you look off in the upper right-hand corner, you can see the chart here, some of the parameters that can be programmed: frequency, pulse width, amplitude, max amplitude, when it turns on, which contacts you want on or off, etc., etc. Again, this would all be done with the app on your phone. And then down here on the left and the right at the bottom are different batteries. You can see some can be thick and big, and some can be smaller. Up here you can see the spot where the leads get pushed into and then secured inside this space here. And then each contact will be can be separately energized using these different contacts in the battery. But if you look at the paddle leads up at the top left, there are these little wires coming off of them. These travel under the skin down to the battery, which is in a different location from where this is inserted onto the spinal cord. And now we'll take a look at some pictures of how that implant is put in and what that looks like. So before we get to how I would actually implant a spinal cord stimulator in a patient, let's talk about who's a good candidate for that kind of surgery. Well, as I said before, their primary problem needs to be pain. That pain will have to be there for at least 6 months and is not responding to conservative or other types of treatment. The pain has to be significantly interfering with the patient's quality of life. The pain has to be neurologic in origin, meaning that it's coming from nerves of some kind. If the spinal cord stimulator is interfering with the communication of nerves and the pain is not coming from nerves, it's not going to be very effective. The patient could have pain from surgery or pain despite surgery. And the other thing is you don't want patients who have a lot of psychiatric or psychological diagnoses on top of their chronic pain. Studies have shown that patients that have those kind of issues like major depression or bipolar disorder often don't get as good results with spinal cord stimulators as patients without those other problems. Part of the screening process for these patients is ruling out those other kind of major psychiatric or psychological comorbidities. So another thing to mention is how a patient like this would get into my office before I would offer them the surgery to implant a permanent spinal cord stimulator. Well, usually these patients are referred to me by pain management physicians. These are physicians that treat chronic pain, and usually what will happen is the pain management physician will work with these patients for many months, sometimes even years, trying to treat their pain with typical or non-invasive methods, medications, therapies, possibly injections. But if after a while those are not working and the patient meets the criteria for someone who might benefit from a spinal cord stimulator, the pain management physician will do what's called a trial spinal cord stimulator. This is an outpatient procedure usually done in the pain management physician's office. And basically what they do is they use a moderate-sized needle to puncture into the space outside of the spinal cord membrane, and then put a small electrical lead on the back surface of the spinal cord. And this is usually a skinny wire with multiple electrodes on them that can fit inside this needle. So they basically puncture the needle through the skin into that what's called epidural space outside the spinal cord. They will then snake the wire lead through the needle, use an X-ray to confirm that it's positioned in the right spot. Usually this will be in the lower thoracic, upper lumbar spine area. And then they'll take the needle out while leaving the electrode in. They'll cover it with a bandage and a dressing. They'll attach that lead to a generator or battery. And then they'll send the patient home with that, and they'll put some settings in it, and they will probably tweak those settings over the next couple of days, and then they'll bring the patient back and say, well, what do you think? Did it help? If the patient describes a greater than 50% improvement in their symptoms, they might be a good candidate for a permanent spinal cord stimulator. At that point, the pain management physician would then refer the patient to me, the neurosurgeon, for implantation of that permanent spinal cord stimulator. Keep in mind, by the way, that when the patient comes back and reports that their pain symptoms have improved, the trial or temporary spinal cord stimulator will just get pulled out of the back. A dressing will cover the tiny needle hole. That'll all heal up before they get their permanent implant. Okay, so the patient's in my office. Their pain management physician referred them for a permanent spinal cord stimulator implant. I agree that they're a good candidate. Usually I will use whatever stimulator the pain management physician prefers, because the pain management physician will basically be managing that stimulator after I put it in. So I'll confirm with the patient that all the information is correct that I see in the pain management doctor's notes. We'll get some blood tests, an EKG, a chest x-ray, make sure the patient is healthy. If the patient has a lot of medical issues, I'll get clearance from their primary care physician that they're healthy enough to be asleep from the anesthesia for the procedure. They'll pick a day. They'll show up in the operating room. We'll bring them into the OR. Anesthesia, we'll put them to sleep. We'll roll them over on their belly on a special table. And then I will clean with an antiseptic solution the middle back area and usually the left flank area or love handle area. I'll use x-rays to determine the appropriate level that I want to put the implant in. And let's say, for example, the pain management trial was very effective on the leads centered over T11 and T12 levels in the thoracic 11 and thoracic 12 vertebral levels. I would then use an x-ray to determine the T12L1 level, because I want to go slightly lower than where it was effective, because when you implant the spinal cord stimulator paddle lead, you're going to slide it up from where it enters. And so if, let's say, I want to get it over the L1, L2, let's say I want to get it over the T11, T12 area, I'll probably put it in at the L1 level. I'll make an incision down the middle of the back, probably about 2 inches long. scrape the muscles off the left and the right side of the bones, and then I'll do what's called a small midline laminectomy, where I will remove the bones off of the lamina in the center of the spinal column. That creates a little window in the bone. I'll then remove the ligament that's usually at that point, and then underneath that ligament I'm going to see the dura, which is the thick membrane covering the spinal cord. I'll then put in what's called a trial paddle, which is a piece of plastic that's kind of more firm than the actual implant, and that creates a little pocket in the space above the spinal cord where the paddle is eventually going to go, and it allows it to be slipped in more easily. I'll then take the paddle lead and I'll slide it along the back surface of the spinal cord up to the level I think it should be, and then I'll take x-rays to confirm that that paddle is where I want it to be. Not only at which level it is, like T11, T12, but that it's in the midline. And I want it in the midline because I want the patient to have free use of all the different spots on that lead, left and right, and be symmetric. So once I've confirmed that the paddle is in the correct spot, I will then take a tunneler and tunnel from under the skin where the incision is in the middle of the back down to the incision that I have made in the left flank area. And that little tunneler kind of slides under the skin, creates a little space for the tube that's attached to the tunneler. And then through that tube, I will pass the electrical leads that are attached to the paddle that's now on the surface of the spinal cord. I'll push those leads through the tube, and then I'll pull the tube out, leaving the leads under the skin. So now the leads are sticking out of the incision that I made in the left flank. I'll then create a pocket in the left flank, usually under the skin and under a layer of fat. I'll put in a trial battery pack, which is the same size as the battery, but it's not the actual battery, to make sure that that battery is going to fit in the pocket that I made. I'll wash the pocket out, make sure there's no bleeding, and then I will attach the leads to the battery, tighten everything down, test the system to make sure that all the connections are good and everything's functioning properly. And then I'll put that battery pack in the pocket I made in the skin, under the skin, in the left flank love handle area. So now the lead is on top of the spinal cord. The wire is under the skin, connecting it to the pocket where the battery is. Everything's working. And then I wash everything out with antibiotic saline and then sew everything up and put staples in the skin. So now the spinal cord stimulator has been implanted from the stimulator paddle all the way to the battery. Cover everything with dressings, turn the patient over, wake them up, take out the breathing tube, bring them into the recovery room. So here we have a picture or diagrams describing somewhat the surgery involved that I talked about. What you've got in the top left is just a quick photo or diagram of the trial lead. It's a skinny electrode with multiple contact points on it that's put through a needle that's put into the epidural space here. So you can see the trial lead resting on the spinal cord. That would be used to test the system for a couple of days to see if it works, and that would be put in and taken out in the pain management physician's office. Moving over to the next picture, to the right of that, you'll see the paddle lead. It's much bigger. This is the more permanent lead. That would be placed through a surgery with the neurosurgeon, again in the same spot as the trial, only the contacts, because there are more contacts on them, would cover more area. Here is a picture of how the system looks on the body when you sort of step back and take a look from afar. You can see the electro leads on the spinal cord, the wires under the skin, going to the battery pack in a pocket under the skin here. Down on the bottom left, you can see sort of a surgical view. Here, part of the spinous process is removed. Here, part of the lamina is removed. That creates that window to slide the paddle lead up to the spot that you want it in, hopefully in the midline. Here's the electric lead coming out of the paddle, eventually heading down to the battery pack. And then over here in the bottom right, you can see sort of a down the tube picture of the spinal cord with the paddle lead above it. That multicolored area is the influence of the paddle lead on the dorsal tracts of the spinal cord. Here's another shot of the paddle lead on the surface of the spinal cord. So this is kind of a summary pictures of some surgical aspects of the spinal cord stimulator. So the patient will be in the recovery room for about 45 minutes or so, letting the anesthesia wear off. They'll probably notice that the middle of the back is a little sore. Even though I do put numbing medicine everywhere, the deeper muscles in the back tend to be the most sore after the surgery. It's not very painful though, not terrible. The flank area usually doesn't hurt much because it's only the skin that hurts, and that's pretty well numbed up. Once everything looks good in the recovery room, the patient will then go back to the holding area where they started out the day. And then as soon as they can walk, pee, eat something, and say that their pain is usually well controlled and that the dressing is nice and dry, we'll let the patient go home. I usually don't let the patient turn on the stimulator for the first 24 hours. Usually the stimulator medical device rep will meet the patient either at their home or in the doctor's office to turn it on 24 to 48 hours after the surgery. One of the reasons we don't like to turn it on right away is some of the discomfort from the surgery, especially after the numbing medicine wears off, can make the patient feel a little anxious that the stimulator is not working because they're still in a lot of pain from the surgery. They'll be back in my office about a week after the surgery for their staples to come out and for us to check the incision. And then they'll be back in my office 2 weeks after the surgery for a final checkup with me. Well, I'll look at their incision. I'll ask them how they're doing. I'll ask them, how they've been doing with the stimulator turned on, how much improvement they've gotten, if they're able to take less pain medicine, etc., etc. I'll usually tell the patient, basically for the first few days after the surgery, to basically stay in the house. That doesn't mean lie in bed all day, but just stay home. They're allowed up and down steps, watch TV, read a book, take a nap, play on the computer, stare out the window, watch the grass grow, that kind of thing for the first couple of days. About a week after the surgery, they can drive, short trips only, the bank, the post office, the grocery store, that kind of thing. But for 2 weeks, even if they feel fantastic, I basically want the patient to be a slug. No bending, no twisting, no lifting more than 5 pounds, no housework, no yard work, no walking the dog, no taking the trash out, no exercise, no home improvement projects, no hang gliding, no skydiving. Basically lay low for 2 weeks. And that's even if they feel fantastic. And the reason for that is we want the tissues around the implant, both the lead, the wires, the battery, we want all those things to start to scar down. We don't want any of the wires to migrate or move from where I implanted them. We don't want that paddle, which is resting on the back of the spinal cord, to migrate to the right or the left. So a little bit of scarring around those things, which occurs naturally anyway after surgery, is a good thing to kind of keep everything where we put them in originally. So at 2 weeks, if everything looks good from my perspective, they've graduated, they're off the hook, they don't have to come back to see me. So what are the risks of this surgery? Well, there are 3 risks for any kind of surgery. It doesn't matter what kind of surgery it is. Same 3 risks. Infection, bleeding, problems with anesthesia. All very low, especially for this kind of surgery, but those are in the book, so I have to tell you about them. And that's why we kind of get the blood test, the EKG, the chest x-ray. Make sure you're as healthy as you can be before you have the surgery. Even though we do all those things, even though we give antibiotics before the surgery, after the surgery, even though we do it in a sterile operating room, there are still risks for infection. And of those 3 risks for any kind of surgery, for this particular surgery, the infection is the most kind of worrisome. And that's because if the spinal cord stimulator gets infected, it often cannot be treated with just antibiotics. The body kind of creates a capsule around the implant, and it's very hard for antibiotics to penetrate that capsule and kill all the bacteria. So if you just try and treat with antibiotics, more often than not, you'll get improvement in your symptoms, but as soon as you stop the antibiotics, the infection comes back. And what that means is that biofilm around the implant has been seeded with bacteria, and the antibiotics can't get to it. So unfortunately, if you get an infection from this surgery, you often have to get the spinal cord stimulator taken out in its entirety. The battery, the leads, the paddle, everything has to come out. You have to be treated with antibiotics for probably 6 or 8 weeks. Be convinced that the infection is gone, and then you can get the implant put back in. But unfortunately, if you do get an infection, it might mean the whole thing has to come out, and you got to kind of start over eventually. There are some risks that are special to this surgery because you are near the spinal cord. You could injure the spinal cord while you're doing the surgery. Knock on wood. I've never done that to anyone, but it's in the books, so I have to tell you that that is a possibility. There are risks of tearing the covering of the spinal cord. That can cause a spinal fluid leak. Again, extremely low risk, but it's in the books, so I have to tell you about it. The stimulator paddle or leads can migrate. It can go off to the left or the right or up or down. If that's going to happen, it's more often a left or right migration. The up or down usually doesn't happen, especially if most surgeons do what I do, which is put in a little anchor stitch around the battery leads near where the paddle goes into the spinal canal. And that way it's not going to really go up or down. The connections between the leads and the battery can corrode or get covered with scar tissue or soft tissue, and the connection can get faulty. The batteries can run out of juice. Newer batteries are rechargeable. Those can usually last 7 to 10 years. The non-rechargeable batteries usually last about 5 years. Keep in mind that how long these batteries last will often depend on how much you're using the stimulator. If you're using it all the time, every day, 7 days a week, 365 days a year, and you're at the highest intensity it can be, you're going to drain that battery much faster. Batteries running out are not really a big deal. It's about a 20-minute outpatient surgery where you just open the pocket where the battery is, take the battery out, put a new one in, close everything back up. So if the stimulator's working really well, you've been using it for a decade, and all of a sudden the battery stops working and you still want to use it, not a big deal to replace that battery. So those are kind of the main risks of that surgery. So some final thoughts before we go. Some benefits of this surgery, big picture. Number 1, reduction in pain. Everybody would like that. Number 2, it's adjustable. You can tweak the settings on the stimulator to kind of adjust it to your particular pattern of pain, where it hurts, what works best for you. The batteries are easily changed if they run out. The secondary effects of decreased pain are often pretty significant. Better sleep, better relationship with others, better ability to accomplish your activities of daily living, maybe better opportunities to work, improvement in pain-related disorders such as mood disorders or things like depression. So a lot of benefits to this surgery. And again, the best way to know if this surgery is going to be of benefit is if the trial stimulator worked. If that trial worked, you got a really good chance that the permanent implant will work just as well, if not better. I usually tell patients you can expect about a 50% reduction in pain. Even if they tell me the trial made them 90% better, I usually give that 50%. Okay, so I was going to cut out the dogs barking, but I decided to just keep it in because now you guys know I am not AI generated. I'm an actual real person. So anyway, sorry about the dogs barking. That won't happen again. Anyway, as I was saying, I usually tell patients 50% reduction in pain, even if they tell me they got 90% better with the trial, because I want to paint the patient a pessimistic picture, relatively speaking, so that they're pleasantly surprised after the stimulator's put in, as opposed to painting this rose garden and have them be disappointed. So usually patients are going to get 50% or greater reduction in pain. So that's as far as expectations are concerned. The other thing the patient should keep in mind is that the spinal cord stimulator is not the be-all, end-all treatment for their pain management. It is part of a bigger picture of treatment that includes many other aspects of treatment. Treatment can include physical therapy, behavioral modification therapy, lifestyle modification, medication, actual pharmaceutical medications. So the spinal cord stimulator needs to be thought of as a tool in the toolbox with many other tools to treat the chronic pain situation. Okay, and then finally, some answers to typical questions patients have in the office when I see them for their 2-week checkup or in the initial evaluation. Big question I get is, can I get an MRI if I have a spinal cord stimulator? The short answer is maybe. Most of the newer spinal cord stimulators are MRI compatible. The older ones often are not. So either way, you need to check with the medical device rep for your spinal cord stimulator to find out if it is MRI approved or not. If it is not, and you have to have an MRI, you may have to have it taken out for the MRI. Another question I get is, can I travel, go through TSA, etc. with this implant? The implant can and probably will beep if you go through the walk-through detectors with TSA in the airports. Your medical device rep will give you a card that you can carry with you in the airport. And you can show that to the TSA security people and get through with your implant. Other questions are, can you turn it off? The answer is yes. In the old days, you would have this little gadget that you would put up against the battery in your love handle area, and that's how you would adjust the settings on the stimulator. Nowadays, it Bluetooths to your phone, and there's an app on your phone, and you can control everything on your phone. But ultimately, you can turn it totally off if you want. As I mentioned before, you can also adjust the settings. Initially, that'll be done in combination with your pain management doctor and the medical device rep. But over time, you may get so good at tweaking the controls that you may be able to, on your own, adjust the settings to try and find that sweet spot that gives you the best pain relief with the least side effects. And again, side effects are unwanted numbness, tingling, a sensation of vibration, that kind of thing. Another question I get is, will people see it? The incision where the implant gets put in the middle of the back, the answer is no, you can't see anything there. There'll be a scar from the incision, but that's about it. The battery pack could be noticeable, especially in very, very thin people, but that love handle area, even in thin people, has a pretty good layer of fat on it that the battery can live under. As you saw from the pictures I showed you earlier, the batteries come in all sorts of shapes and sizes. The bigger they are, the longer they last, but there are some relatively thin batteries that are very hard to kind of feel or see. If you're a very thin person, the short answer is you'll be able to feel it, and maybe some people could see it. If you're a very large person, you're not going to notice anything, and nobody will be able to see anything. And then finally, another question I get a lot is, will insurance cover this? Usually the patients that end up in my office have been through the pain management physician's trial period. And usually if an insurance company approves the trial, that means they're going to approve the permanent implant. So the typical answer to that question is yes. Usually medical insurance companies will cover this for treatment. You may have some hoops to jump through, and you may have to have your pain management physician document that you've been through certain treatments before this that have failed in order for them to cover it. That is the relatively short talk on spinal cord stimulators. I tried not to get too much into the weeds about pain pathways and how the electronics of this work. So I hope this is just enough to kind of get you through the time before you see your neurosurgeon for your appointment to kind of learn about the permanent implant of the spinal cord stimulator and kind of lower your anxiety and maybe worry about the procedure. So I hope that helped. If it did, please like and subscribe to the channel. For those of you with chronic pain or family members of people with chronic pain, there are a lot of other videos on my channel about spinal problems that cause these kinds of pain. Please check those out if you'd like. And then last word on spinal cord stimulators for the arms and neck. They are implanted in that area. I've done a few of them. I'm not a big fan of spinal cord stimulators for neck and arm pain. If the patient is totally miserable, everything else has failed, the trial worked, I might be able to be talked into doing it, but overall my success rate with cervical spinal cord stimulators has been much lower than with lumbar or thoracic spinal cord stimulators. There are various reasons why this might be. The spinal cord in the neck is much thicker. There's not as much room in there for the implant. And the anatomy of the nerve pathways are a little different in the neck. There's certainly more fibers in the neck because not only are all the arm and trunk fibers in there, but not only are all the leg and lower body fibers in there like they are in the thoracic region, but now all the arm pain fibers are in there too. So you have a lot more nerves in there to deal with than you do in the thoracic lumbar region. That doesn't mean a cervical spinal cord stimulator can't be effective or wouldn't be worth it. I just wanted you to be prepared that the outcome and success rate may not be as high as with the leg and low back problems. So that's spinal cord stimulators, what they are, how they work, what they look like, how they're put in, the risk benefits, and what to expect before, during, and after that surgery, and a little bit of general questions and answers about that I typically hear from patients with this kind of procedure in mind. So I hope that helped. I hope it was worth it. Don't forget the most important thing you can do: stay healthy.